Assalamu alaikum, masal khair. Good evening, everybody. My name is Ibrahim. I'm a neurosurgeon, and we are transmitting live from here from Amman, Jordan, at the Farah Medical Campus, which you can see on the backdrop of the slide. Okay, we are, as Muslims, we believe in God and His prophets, and among these prophets is Jesus Christ, so we believe very much in Jesus Christ. And I just want to show you the baptism site in Jordan. The baptism is when St. John the Baptist baptized Jesus Christ at the river Jordan. And the Matthew treats, as soon as Jesus was baptized, he went up out of the water. At that moment, heaven was opened, and he saw the Spirit of God descending like a dove and lightening on him. These are the famous paintings depicting the baptism, and this is one of the Leonardo da Vinci paintings, in addition of a few others by famous painters. If you look at the mosaic maps in Jordan, this is supposed to show River Jordan, and this is the Dead Sea. And it shows from many, many hundreds and thousands of years ago the site of baptism. So the baptism site in Arabic, Al-Maqtas, is literally beyond Jordan, where John the Baptist church is, and which was established by the Emperor Anastasius a very long time ago. It is one of UNESCO World Heritage Sites. This is the panoramic view of the Al-Maqtas, or the baptism site in Jordan. And this is the Basilica of Church of Trinity down there. This is the baptism pool where the people would go into the baptism pool like this. This is the famous pool. And this is the Pope visiting us about a year and a half ago, and he went down these marble steps into the water. So all over the world, people recognize the baptism site is in Jordan side, not in the Israeli side. The topic for today is the trigeminal schwannoma, the clinical, radiological, operative, pathological correlation. I have to go quickly, so please bear with me and concentrate with me because it's a long topic. So speaking about the trigeminal schwannoma, let's look at the anatomy of the trigeminal nerve. This is the anatomy of the trigeminal nerve, and you can see that this is the root or roots causing the gazillion ganglion, dividing into V1, V2, V3. V1 is called the ophthalmic, V2 is the maxillary, and V3 is the mandibular. V1 goes through the superior orbital fissure, V2 goes through foramen rotundum, and mandibular goes through foramen ovale. As soon as this nerve goes into the superior orbital fissure inside, most of it inside the annulus of Zem, it divides into many branches. These are the branches. There is one branch which is important, and it has a clinical significance. This is the meningeal branch of the ophthalmic to the dura. It goes back like this, and this has a very important reflex. So this, V1, gives a meningeal branch, V2 gives a meningeal branch, and V3 gives a meningeal branch. So when we open the dura, sometimes there is a reflex, and Dr. Faras will tell you about that, because it's very, very important. So the branches of this is the meningeal branch, the frontal branch, the lacrimal branch to the lacrimal gland, and the nasociliary related to the nasociliary ganglion. The mandibular goes into many branches: the superior alveolar, the submandibular, the zygomatic, and the nasociliary, nasopalatine. The mandibular has most of the time some sensory and some motor. So these two nerves are sensory. This is mixed sensory and motor. giving muscles of mastication, which are the masseter, the temporalis, the pterygoid, the medial pterygoid, and lateral pterygoid muscles, in addition to other muscles like tensor palati and tensor tympani, and the mylohyoid and the anterior belly of digastric. It is related to the otic ganglion, so otic ganglion related to the mandibular, and the pterygopalatine ganglion related to V2, and the ciliary ganglion related to V1. Let's go back to the roots of the trigeminal. These are the three nuclei of the trigeminal nerve: the mesencephalic nucleus, the main sensory nucleus, and the spinal nucleus, together with the motor. So this small one is the motor. These three are sensory. That's why the trigeminal is mainly sensory for the sensation, and small part of it is in the motor. So here it is. Comes out from the pons, and it goes out to Meckel's cave and then into the Gazerian ganglion. So magnified view, the three nuclei form the sensor root. And then the motor nuclei, which is the small one, goes like this. It comes off the frontal part of the pons. So most of the nerves are on both sides. These are only the abducent here is in the front. The third nerve, oculomotor, is in the front. Trigeminal is on the side. So this is, again, the frontal view of the brainstem. And you can see the trigeminal nerve here. And these are the abducents. So the trigeminal nerve would come this way, here into this place called the trigeminal impression. And then here the Gazerian ganglion will form. And then one root will go into the foramen ovale, which is the mandibular. And then the V2 goes this way, and V1 go through the severe orbital fissure. This is the foramen lacerum for the carotid. So if we take the skull into separate bones, this is the sphenoid bone, the temporal bone, and the occipital bone. We are concentrating here on the sphenoid bone. And all these foraminae I mentioned are within the sphenoid bone. Foramen ovale, and foramen rotundum, and severe orbital fissures. So only this foramen, which is called foramen spinosum, for the middle meningeal artery. Foramen ovale, foramen spinosum, foramen rotundum, severe orbital fissure. And if we are looking from anterior view, you can see the severe orbital fissure, and you can see the foramen rotundum for the mandibular nerve, because this is the pterygoid plates. So this is where the pterygoid plexus is and pterygopalatine ganglion is. So V2, the maxillary, would come out here. This is another canal called Vedian canal for the Vedian nerve, which is a mixture of parasympathetic and sympathetic. This is a back view. You are looking from the back, and again you can see the severe orbital fissure, and you can see the foramen rotundum and foramen ovale. These are the pterygoid plates. Again, if we magnify the view, this is the petrous apex. This is the impression for the trigeminal. This is the foramen lacerum. This is the foramen ovale, foramen spinosum, foramen rotundum, severe orbital fissure. So the Gazerian ganglion is here. It gives V3, V2, and V1. So you can look here at the trigeminal impression, foramen lacerum. And this small sulcus here is for the abducent nerve. So the trigeminal will go into the Meckel's cave, like this one here. These are the two trigeminal nerves. These are the sixth nerve, the 7, 8 on both sides, and the lower cranial nerves. This is a very important venous plexus at the back of the occiput, the back of the occipital bone. So trigeminal going into Meckel's cave, 7, 8 into internodentral meatus, and the three nerves glossopharyngeal vagus accessory going through the jugular foramen. And here are the hypoglossal nerves. And there is a very important relationship when the trigeminal roots form the Gazerian ganglion. They go into the Meckel's cave. And then here we have the severe petrosal sinus. So this could be above the nerve, it could be below the nerve, it could be surrounding the nerve. So here it is, pons, and this is the roots, the sensor roots and motor root forming nerve. and then the division into the Gazanian ganglion within the Meckel's cave. If you look here, the large one is the sensory, the motor one is the motor. So whenever you look here, you can see the nerve and the Meckel's cave. So who is Meckel's? Meckel's is a German anatomist, Johann Friedrich Meckel's, who discovered the Meckel's cave. So the trigeminal going into Meckel's cave, dividing into V3, V2, V1. This is the abducent going underneath the Gruber ligament through the Dorellus canal into the lateral wall of the cavernous sinus. Magnified view from a cadaver. These are the 7/8 nerve going through the internodutium hiatus. This is the trigeminal going into the Meckel's cave and dividing it to 3 branches. This is the inside view of the left temporal bone. This is the temporal bone, and this is apex of the petrous apex. This is internodutium hiatus. So this is the impression for the trigeminal nerve. So trigeminal nerve into ganglion, V3, V2, V1, and this is foramen spinosum. Underneath the trigeminal is the petrous part of the carotid artery, and here is the facial nerve into its geniculate ganglion, giving a greater occipital pterosal vein. So V3, V2, V1, foramen spinosum, and this is the petrous apex. This is the carotid, and the trigeminal is on top of it. Again, trigeminal is sitting on top of the carotid. So if you remove the trigeminal, you will come to the carotid, you will find the Gruber's ligament, and underneath passes the abducent nerve. And last lecture, when we discussed describing the abducent nerve, we mentioned these scientists, Gruber, Gardeningo, Dorello, and Vail, who described this anatomy. A very famous paper by Kawase about the layers of the dura surrounding Meckel's cave. It's very interesting. I recommend it for reading for every neurosurgical resident. So here you are. This is actual cadaver. This is the trigeminal nerve. This is ganglion, V3, V2, V1. V1 into the severe orbital fissure, V2 into rotundum, and this is into ovale. This is the dura covering it. And if you remove it, you will come into the cavernous sinus. So this is the cavernous sinus. Again, magnified view showing the facial nerve, the geno of the facial nerve, and to the tympanic part, and then this is the greater superficial petrosal nerve. So this is important anatomy that we need to remember. This is the Kawase triangle. This is the carotid. This is the greater superficial petrosal nerve. And here is the eustachian tube coming from the middle ear into the nasopharynx or pharynx. Magnified view to show the greater superficial petrosal nerve, just lateral to the V3. Why am I showing you this? Because you are going to see this anatomy on the video when we show it. So V3, Kawase, carotid, greater superficial petrosal nerve, eustachian tube. Repetition. So this is my landmark. If I want to do surgery, I define what is the middle meningeal. I know what is V3, so this is my limit. This is my limit, this is my limit. So it's called the quadrangle or Kawase triangle. Here V3, V2, there is a space here, there is a space here. And this is the Gazanian ganglion within the cavernous sinus. So this is the cavernous sinus, and it's a great anatomical interest. If you know it, you have unlocked the secrets of the brain surgery there. And my interest in the cavernous sinus was from the very beginning. I love this area, and I love the anatomy of it. And early on, 1984, I published my first paper about the cavernous sinus, traumatic carotid cavernous fistula. This is in Journal of Neurosurgery, 84. I was a little baby in the neurosurgery when I published this. So we are now in the cavernous sinus on both sides of the pituitary. The cavernous sinus, you have the carotid. This is the oculomotor nerve, trochlear nerve, V1 which is inside or in the lateral wall of the cavernous sinus, and V2. So the cavernous sinus stops at the upper level of V2. So let's look at the ophthalmic division. As we said, the branches, we mentioned them, the 4 branches, the meningeal, the frontal branch, the lacrimal branch, and the nasociliary branch. And there they are. So this is the branch going to the lacrimal gland, the lacrimal nerve. Inside here is the nasociliary nerve, and here is the frontal branch, which is sitting on top of the superior rectus and the levator superioris. As it goes through the annulus of Zen, the 2 nerves, the lacrimal nerve and the frontal nerve, are outside the annulus of Zen. V2, as we said, has many branches. It's mainly for the upper jaw, the superior alveolar nerve, and the buccal nerve, the labial nerve, the zygomatic nerve, and the submental nerve coming as a branch from the this nerve here. It's called nerve of kissing because it's relating to the sensation for the lips. So all the facial auxiliary surgeons call it nerve of kissing. So here it is, the 3 branches. This is the V2 coming forward like this. Mandibular nerve, V3, divides into sensory and motor, because this is the only motor part of the trigeminal nerve. All of it is sensory except small part here within the trigeminal nerve. It gives the inferior alveolar nerve, which branches and come here out as the mental. This is of interest for the dentists, but we have to know it as well. And it is related to the otic ganglion, and it has a relation with the chorda tympani of the facial nerve. So the trigeminal nerve supply half of your tongue with the normal sensation, and it also carries half of the sensation of your tongue through another nerve, which is the chorda tympani going to the facial. So we know now the anatomy of the trigeminal nerve. What about the schwannomas arising from the trigeminal nerve? As we said last time, schwannomas arise from Schwann cells. So they don't arise from olfactory nerve or optic nerve. They don't have Schwann cells. All the other cranial nerves, they have Schwann cells. So you can have schwannoma from any nerve except the olfactory and the optic. But also, in addition to the cranial nerve, they can arise from any peripheral nerve or even autonomic nerve, sympathetic or parasympathetic. What is the difference between schwannoma and the neurofibroma? As the Schwann cells are on the periphery, so when they form a tumor, they are on the periphery. You can actually excise it without damaging the nerve. While neurofibroma comes from the connective tissue of the nerve, so you cannot separate the tumors. This is the difference between neurofibroma and schwannoma. The commonest schwannoma in the body is the vestibular schwannoma. Schwannomas in general form 7% of all intracranial neoplasm. Again, they are common in females, like in meningiomas, and they arise mainly from sensory nerves. But last time we have shown the abducent nerve, which is motor nerve, yet we have schwannomas. So whether it is sensory or motor, you can have schwannomas, but it is more on the sensory. And the vestibular, coming from the vestibular nerve, is the commonest. Followed, the next common is the trigeminal, lower cranial nerves, mainly the vagus, facial, and so on. Next time, I'm going to present a case of facial schwannoma. So schwannomas in general, trigeminal schwannoma forms 80%, because the schwannomas, cranial nerves, about 90% are from the vestibular. The rest are coming from the other cranial nerves, and 8% are coming from the trigeminal. It could be solitary, it could be multiple, it could be part of neurofibromatosis or bone Recklinghausen disease. And these are my cases of bone Recklinghausen disease or MF2. This is a young man from Irbid, 16-year-old male patient with this trigeminal schwannoma, and in addition to bilateral acoustic schwannoma. And also we have cavernous sinus meningioma. Very unlucky. This is another unlucky male patient, 11-year-old, with this huge giant schwannoma and acoustic neuroma and cavernous sinus. meningioma. Schwannomas can arise from the trigeminal nerve, whether it is from the cisternal part, or from the ganglion, or from the divisions. So you can see different types of these tumors. So if it comes from the root, this is the schwannoma, this is the gazillion ganglion. Here it is dumbbell, affecting both, and you can see it there. So this is dumbbell in the middle fossa and in the posterior fossa, underneath the edge of the Michel's cave. It has been classified by many surgeons and anatomists, very interesting classifications. I know them all, but I would confuse you if I just mention each and every one of them. Roton, Sami, Dollins, Ramina, Fukushima, etc. So I just want to put the pictures of these people so that we will all remember them as great giants and mentors who taught us anatomy and surgery. Myself with Roton, with Majid Sami, with Dollins, with Osama Rifti, with Kawase, and with Ali Crest. So Jefferson classification, I'll just pass it. There is the Fukushima classification. This is the Kawase classification. This is Ricardo Ramina classification, a very famous classification. So he divides them into type A, B, C, D, E, F, like this. Type A is peripheral. So this tumor is in the orbit. So in the orbit. Extracranial, peripheral. This is in the maxilla, affecting V2. This is another example of another schwannoma in the maxilla going into the infratemporal fossa. And this is V3 going into the infratemporal fossa. Now this is type B, mainly in the middle fossa. Type C, small part is outside. Again, this is mainly the posterior fossa. This is dumbbell, both. And this is intracranial and extracranial. I'm just putting this Ramina classification because it is, you can visualize it like this. But the simplest way of understanding this way is Majid Sami classification. So simple, so direct. Either the tumor is mainly in the middle fossa, or mainly in the posterior fossa, or in both, or it has extracranial extension. I think this is very nice middle fossa example. This is very nice example of the posterior fossa, and this is example of both dumbbell. So middle fossa, posterior fossa, or both. Simple and easy. Can these schwannomas, which are benign tumors, tend to be malignant? Yes. Either de novo, meaning that it is a benign tumor that transforms into malignant, or it is malignant from the beginning, and this is usually associated with von Recklinghausen disease. So neurofibromatosis is a very bad disease. The names for these malignant schwannomas, they call it malignant neurofibroma, neurofibrosarcoma, neurosarcoma, neurolymphoma, or malignant nerve sheath tumors. So they can be malignant. And this is one of the papers from USA describing this malignant schwannoma. How do they present? You would think because it is trigeminal, they would present with trigeminal neuralgia, which is correct. This is the commonest thing. And you will have a patient come to you saying, I have pain in here. And they say, oh, this is nonsense. Trigeminal hyposthesia, في عندي خضران في الوجه. Diplopia, pain in the eye, pain in the ear. في عندي نمنمي هون، في عندي وجع في إذني، وجع في رقبتي. Psychological, usually female. That's what we do. So what is the treatment? The treatment is surgery. Surgery first and foremost. Other than that is nonsense, basically. How do you reach the trigeminal? You reach it via many approaches, not only via open surgery, but recently also via endoscopy. Surgery prior to 1956, mortality rate was 50%. So you could see how advanced we got in this type of surgery. Why? Simply because we know anatomy much better now. So the treatment of choice is surgical. The goal of surgery is complete resection, not a biopsy followed by radiation. This is a crime against humanity, which is committing every day in every bloody hospital, I'm sorry for the word, in Jordan. Neurosurgeons need full 3D anatomical knowledge that can only be acquired in the cadaveric lab. And who goes to the cadaveric lab? Nobody. Importance of using the interdural space. This is anatomy. If you don't understand it, you cannot understand what we are talking about. And this is very, very alarming. Most neurosurgeons seldom have the opportunity to operate on any single case. Our neurosurgeons are busy doing burr holes or doing a disc or doing gamma knife. So surgery is for complete tumor resection. This is the norm. Why? We have advanced. We know anatomy well, imaging is well, physiological monitoring, and we mastered the skull-based approaches. Let's see this one. This is giant infratemporal. So the incision is parapharyngeal here for the surgeon to take it. Again, this is famous paper, as I said, by Kawase, who described this interdural. This is the Michel's cave and how the arrangements of the dura around it. Look at this, very interesting. The dura is made of two layers, the industrial layer and the dura proper. And then there is another layer which is covering the nerves. So if you don't know this principle of anatomy, you can never ever operate on trigeminal schwannoma. Dumbbell shaped, this is by Osama al-Mufti. Osama is of Syrian origin, working in Harvard. Ilhan Shaker from Seattle, again described this non-vestibular schwannoma of the brain, his experience in it. Atul Goel, a friend of mine, is a master of skull-based surgery from India, and he and I are always fighting who has the largest size of the tumors. Because in India, as well as in Arab world, they go into huge size before they are coming into attention. Again, he described this. Previous paper was on 73 cases, but then he published this one on the with the extracranial extension. So extracranial extension is the secret here. You can do lateral orbitotomy for this tumor going into the orbit. So lateral orbitotomy, you remove this so that you can go into the orbit. Or you can do it via endoscopy, and I keep saying that in endoscopy lies the future of neurosurgery. Not now, but in maybe 20 years' time. With the advancement, with the refinement of the endoscopes and the long learning curve of endoscopists. These are the people who are famous. Here we are on a boat trip in Sharm el-Sheikh with these famous endoscopists. Fred Gentili, Paul Gardner, Snyderman, Amin Kassam from Chad. He lives in the States. So Amin Kassam published this paper, and he called it the front door to Michel's cave. Intermedial corridor and the expanded endoscopic intranasal approach. Technical considerations. This is the carotid, this is the abducent, and this is the Michel's cave here, so they can go in there now. Another paper about endoscopy from Vijay Anand from India and Theodore Schwartz, describing their technique in this area for trigeminal schwannomas. And again, another endoscopy, the approaches they use. Look at this piece of anatomy. We've never looked or seen such pictures before. Again, another endoscopy by Snyderman. Here's the before surgery, here's after. So they are still at the beginning. They're still leaving tumor, but they will reach there. Another paper by Theodore Schwartz again. This is before, this is after. So still there is a tumor there. But this is how you push the envelope, by just trying your best to master your technique. Again, endoscopic transorbital. So you go there. This is another endoscopy paper from Korea describing 25 patients. Again, they are living tumors. So this is before, this is after. It's not good, but it is something on the way to master it. So you can do surgery assisted by endoscopy, like this paper by Majid Sami. He says that if you drill this suprameatal tubercle, you will open your way into Meckel's cave. This is the demonstration that when you drill, you open the way to Meckel's cave. I respect that. Radiation, mainly gamma knife. These are the papers published and the number of patients. And I always look at this, tumor control. What does that mean? 100%. You don't believe that in any paper. 90% means that the tumor remained as it is or reduced in size, but never ever vanish. So radiation never cause a cure for that matter. And when I speak about gamma knife, I speak out of advantage point. I am a user of gamma knife. I know how to use it. I've been trained to use it. And this is the first gamma knife machine in the Middle East. I bought it back in '96. So when I say what I'm saying, I know what I'm saying. And I keep saying, a fool with a tool is still a fool. Some of the papers, again by Dave Lansford in Pennsylvania. This is before and this is after. This is before and this is after. So you never cause the tumor to vanish. If I'm a patient, I don't want to have a gamma knife because at the end of the day, I know I still have the tumor inside my head. And I am always at danger that this tumor may flare up and may even turn to be malignant. Again, before and after, they call it good control. I don't call it that at all. So decrease in number, 56, increase 19%, stable, 25. Stable means the tumor is the same. I will not cause it stable. And by the way, stable is a loose term which is used by our nurses and doctors. When you phone them and say, how is the patient? They will tell you his vital signs are stable. So maybe he's dead, but his vital signs are stable. So stable is a stupid word that nobody should use. Yes, exactly. This is because gamma knife is still young, so people are now discovering that after 10 years, it will come back.
Even stable doesn't mean that he's improved.
Absolutely. And usually in the trigeminal,
the aim of the surgery
is to cure
the patient.
Absolutely.
Dr. Ibrahim,
yes.
بالنسبة للإندوسكوبي, apart from intraorbital, what other site do you go for that?
Intraorbital, intrasphenoid, and then you go laterally and into the, yes, so
you don't use any in the skull outside.
They do, vitrosigmoid, they do that.
Okay.
And they go through the maxilla into the pterygopalatine fossa, and they go into the median canal. So it's really improving. So no more endoscopy is something in the ventricle. They can go into the maxillary sinus, into the mastoid, everywhere. It is developing. So again, pointing out to the control, which it doesn't mean anything to me. But it's a loose word to say that they have done something for the patient. To me, it's not convincing. This is a good question. This is a very good paper. I read it with interest. Gamma knife surgery and trigeminal schwannoma. Is it possible to preserve cranial nerve function? And the answer basically is no. Let me read here. Conclusions. I will read it for you, cannot. The use of Luxor gamma knife to treat trigeminal schwannoma resulted in a high rate of tumor control, which I'm telling you, control. However, cranial neuropathies are bothersome complications of radiosurgery, and the tumor expansion is the cause of this complication. So loss of central enhancement could be used as a warning signs of cranial neuropathies. So people got worse, not better, from the trigeminal schwannoma and others. Again, this is their paper. I'm just showing you it before surgery, 32 months after surgery, still there. If I'm a patient, I don't want to see this. Again, tumor control. So tumor control is a loose word. It is very deceiving, like stable vital signs. And this very interesting paper about pseudocapsule formation after gamma knife. So they give gamma knife and they develop pseudocapsule. This is expansion and it needs surgery now. My series of trigeminal schwannomas, since I came back from England 85 till now, 38 patients, which is a very big number. And this is some of the pictures ranging from the small to the huge, and the range in the middle. One of my patients is this 43-year-old patient, male patient, just to show you what we call the winking sign. This is Meckel's cave free. This is Meckel's cave within a tumor. So as if these are two eyes and the patient is winking for you to tell you, I have a tumor there. Winking sign of trigeminal schwannoma. This patient, again, 15-year-old female with this schwannoma going into the orbit and destroying the bone completely. This is a very interesting case which has it's unique because I could not find anything in the literature like it. I called it a triple pathology. Maybe this is the only case in literature. Triple pathology, arachnoid cyst, acoustic schwannoma, and the trigeminal schwannoma. So kissing schwannomas. When I went in, I thought this is one tumor, acoustic schwannoma. I removed it, and then there is another tumor. And the one arising from the vestibular, one arising from the trigeminal. Female to males 17, females 15 males. Usually 2 to 4 centimeters and above is a good number of them. I could achieve total excision in 23 cases, subtotal or near total in 9 cases. I had recurrence in 2. Post-operative cranial nerve deficit shift was the commonest for patients. Others like 3rd or 7th, etc. 6 cases, 6 patients, CSF leak in 2, hematoma in 1, but I had no mortality. There should be no mortality in trigeminal schwannomas. Let me show you some illustrative cases. One case of mine, 62-year-old female who is a Jordanian living in Dubai with this dumbbell-shaped schwannoma. This is before surgery, this is after surgery. And this 35-year-old female patient from Irbid with this huge schwannoma before and after surgery with long-term follow-up. And this is 52-year-old female unlucky lady from the West Bank of Jordan, from Palestine. And this is dumbbell, a huge dumbbell-shaped tumor that we could remove. This is, I had really to put some tarsorrhaphy for her because the trigeminal nerve was very much affected, so I was worried about corneal ulceration. But you can see that it was removed completely. So look, coming to the case of presentation of ours, the schwannoma trigeminal. I sent you these pictures, so this is the case that I'm going to present. 50-year-old Jordanian lady, 10 years, again, she's living in Qatar with her husband and kids. She complained of headaches, left ear pain, and tinnitus. And whenever she goes to the doctors, they would give her drops for the wax. This is a common trick by the NT people, like common trick by the ophthalmologists. They give her eye drops for the ear, for the wax, because she has pain and tinnitus. Oh, no, don't worry. 10 years. She had hypothyroidism, past multiple history, cholecystectomy, tonsillectomy. Vital signs were normal. General examination was normal, but she had this cholecystectomy scar in her abdomen. Glasgow Coma Scale 15/15. Again, Glasgow Coma 15/15 is misleading. Glasgow Coma Scale is describing the level of consciousness. It does not describe the neurological condition of the patient. I may be Glasgow 15/15, but I am hemiplegic with the 3rd nerve palsy and facial palsy. Because you scored the highest from both sides. Eye movements were okay. Facial was okay. No cerebellar signs. No pyramidal weakness in her lower limbs. This is the lady before surgery. chest X-ray ECG normal, CBC bleeding profile normal, kidney functions, electrolytes normal, liver function normal. What about her preoperative image? This is T1 before contrast, and this is after contrast. You can see there is a tumor occupying the middle fossa and the distal fossa. So this is dumbbell tumor, pressing on the pons like this. And if you look here, see the difference in the cavernous sinus here and here. You can see the pushing of the carotid. This is with fat saturation. This is the tumor on the nickel scale. It is going into the posterior fossa. You can see again the cavernous sinus normal here. Cavernous sinus here is very much impeded. So people would say, why should you go to the cavernous sinus? I don't like to go to the cavernous sinus, but I know the anatomy, and if the tumor goes there, I should go there. But don't say cavernous sinus is not. This is, it was no man's land, now it is not. Here is the T2. This is frightening. This is the shadow of the cavern of the petrous carotid. Here we don't see it, meaning that it is very much related to the tumor. And here we're approaching to the internal detritus. Again, you can see the tumor. This is coronal. Again, look at the cavernous here sinus and look at the cavernous sinus here. This is the sagittal. This is the CT scan with one window. You can see the petrous is eroded. So the petrous apex is eroded, just leaving the anterior wall of the internal detritus. Look at here, the alligator mouth. This is normal internal detritus. This is destroyed. The roof of the internal detritus is destroyed by the tumor. So this is long standing. Again, we have to do the MRI, MRV as part and parcel of the MRI. Again, the differential diagnosis. People would say, you are always hammering us with these tumors. Is this reality? It is. I mentioned it in the abducent, and here we'll expand it a little bit. So Schwannomas in general. As we are in the cavernous sinus, there is the third nerve, this is the fourth nerve. So oculomotor, Schwannoma. Trochlear nerve, Schwannoma. Trigeminal nerve, Schwannoma. Abducent nerve, Schwannoma. And the vestibular Schwannoma. Continue, facial Schwannoma. I'll present this case for you next time. Facial nerve Schwannoma. Schwannoma of the jugular foramen. Which nerve? Glossopharyngeal, vagus, accessory. You discover that at the time of surgery. But these are examples of these tumors. This is accessory nerve. This is hypoglossal nerve Schwannoma. Again, I'll present to you this hypoglossal nerve Schwannoma. It could be petroclival meningioma. Could be chordoma, chondrosarcoma, epidermoid tumor, hemangioparasitoma, endolymphatic carcinoma. These are actual cases, and these are all cases of mine. I'm not bringing anything from books. I have plenty of these pictures to show you that these are real cases. The Gliomas jugulare aneurysm. Here it was the aneurysm of the basilar, cavernous, hemangioma, metastasis, glioma going laterally, dermoid and epidermoid, neurosarcoidosis, histiocytosis. They love the petrous apex. They love. Why? I wouldn't know. Histiocytosis love the skull base. Fibrous dysplasia, they love the skull base. Lipoma. And this is cholesterol granuloma. And this is lymphoma. Hemangioblastoma. Hemangioblastoma, yes. Giant cell tumor. And the lymphatic sac, as I mentioned. Large medulloblastoma. And this was metastasis again, and this is arachnoid. Histiocytosis is one mentioned, ependymoma, ATRT, choroid plexus. They are always looking like tumor that unity. This is very important. How many cases I received referred to me for surgery because these are tumors, and they are not. simply because the person referred them have no idea about anatomy, have no idea about pathology. These are simple fusion in the petrous apex. This is what we call fatty marrow, difference between the marrow within petrous apex here and petrous apex here. This is normal. People would give them gamma knife because they have not come across any case like this. Mucocele of the petrous apex, apical petrositis needs medical treatment by antibiotics. Or encephalocele, the temporal lobe of the brain is herniating here. The frontal lobe can herniate through your cribriform plate and present like a mass in your nose. And how many kits were opened in size, and the surgeon found that CSF is coming out. So we did a few consultations, but before that, Ala would like to comment as usual.
Thank you. From an medical oncological perspective, chemo does not work in schwannoma, end of story. However, I cannot hammer the point enough. I've destroyed many a table by hammering it in meetings, insisting upon knowing what the lesion is before subjecting patients to radiotherapy. And if it's not schwannoma, and these are actual cases, and these patients are subjected to radiotherapy, look what you can be missing. Now, chondrosarcoma, the mainstay would be surgery because radiotherapy wouldn't work and chemotherapy wouldn't work. But you don't want to miss a metastasis because the patient was not examined properly, and you have dealt with the met with the focus, the primary focus is elsewhere. You definitely don't want to miss something like histiocytosis, which would not need neither surgery, nor radio, nor chemotherapy, or sarcoidosis for that matter. And the only thing they would need would be steroids and close follow-up. You definitely don't want to miss lymphoma in the CNS, be it a primary CNS lymphoma or a lymphoma secondarily involving the CNS from the body, where the treatment mainstay would be methotrexate in high doses in primary CNS lymphoma, with radiotherapy left to salvage. And if these patients would improve on steroids and radiotherapy initially, and ultimately they would progress and succumb to their disease. You definitely don't want to miss giant cell tumor, the treatment of which would be an anti-resorptive agent that's given once a month in the clinic. Medulloblastoma, after the surgery, the mainstay would be craniospinal radiotherapy and cisplatin-based chemotherapy. Ependymoma, again, the mainstay would be surgery followed by radiotherapy and then platinum-based chemotherapy. These are actual cases, and I cannot count how many tables were destroyed by hammering upon them, and these mistakes continue to happen. Once radiotherapy given focally to these patients without tissue diagnosis, the evidence is buried. And when we get to the series that you were so kind to present with long-term control, if you don't have actual pathology before that, you can't definitely talk about your long-term control in your series, because these are actual cases that masqueraded as schwannomas. They could have been treated as schwannomas with gamma knife.
Thank you. So we did a few consultations. Ibrahim Sadat, are you on?
Good evening. So basically, the function and structure of this patient is very good. His vision is perfect, 1-1. Hair vision is perfect, 1-1. Color vision is excellent. Intraocular pressure is good. There is no any ocular motility deficit. And her fundoscopy, there is no edema or pallor of the optic disc. Visual fields are good. Usually, we do the visual field right in the right and left in the left. Okay. That's it. Okay, thank you.
ENT, Mahmoud Al-Asad, can you come over, please? Mahmoud will not give drops for the earwax.
I am going to comment on that. It looks all okay. There is no abnormality seen in the what audiology or tympanometry or cerebral reflexes. But if Dr. Ibrahim allow me, this is what we do about the tympanometry with the pressure. This is the reflexes, high reflexes. This is nothing to do with the tumor. And there is a bilateral sensorineural hearing loss, high tone. It's not much related to the problem. I just want to talk about tinnitus, if you allow me, because we are accused that ENT is, neglecting. We have a very, very common symptoms called tinnitus. In 2003, there was about 10 million in the United States complaining of tinnitus. And in Germany, it's about 4 million. I don't know, I don't have any records about Jordan, but I think most of the people are having tinnitus. Now, tinnitus is not just only an ear symptoms. In my belief, it is intracranial problem. So either it is vascular or a tumor or whatever it is, and it is most of it referred to the ear. So it's not the job of the ENT to diagnose, because if anyone in the ENT come and talk to me that he has a tinnitus, and I will do for him MRIA and MRIB, they will push me, they will kill me, This is because it means the misuse of all the investigation for the very common symptoms. In my belief, very few due to the ear, because back to 1980, I make research in Glasgow, and I find that some of the what we have, sensorineural hearing loss and tinnitus, it's not because of the ear. The sensorineural hearing is due to the masking effect of the tinnitus. Because there is tinnitus, when we do for him an audiogram, this sound will not allow him to hear a low frequencies, threshold. And this is why he will appear for the audiogram that it is, he have a sensorineural. So this is what I want to stress, that if I don't find anything in the ear, should I send him to the neurosurgeon or to the neurologist to investigate the blood supply, the ischemic, everything?
So basically, he does not use eardrops. Muhammad Juma is around. Muhammad Juma was consulted because she had low TSH and he increased the dose of thyroxine. May I remind you that you should not do any surgery on any patient before you do T3, T4, TSH. This is basic routine investigations, because if you want to put the patient under anesthesia and he is hypothyroid, he will never recover from anesthesia. Anesthesia was declared fit for the general anesthesia. Remember when I told you about the frontal nerve, the maxillary nerve, the mandibular nerve, that each of these nerves, in addition to their branches, they send a branch to the meninges, to the dura, to supply it. And this has very important connection. Let's hear Dr. Faraz. What is the relation of this nerve supply of the trigeminal to neurosurgery and anesthesia?
Assalamu alaikum. Masha al-khair jami'an. Thank you, Dr. Ibrahim, for always giving us the chance.
This is our consent form. We'll just move.
Okay, so I'll be discussing very quickly and briefly about what is called the trigeminal cardiac reflex in neurosurgery. And throughout the lecture, my presentation, you will understand exactly why this is extremely important, not only intraoperatively and not only in neurosurgery, for different types of surgery. And it's extremely important in our daily life, and we'll see why. This reflex is called the trigeminal cardiac reflex. It's one of the most powerful brainstem reflexes related to the stimulation of any of the sensory divisions of the trigeminal nerve. As Dr. Ibrahim has stressed, that has 3 divisions, and most of most of the sensory supply for the skull, the face, the mandibles, our teeth comes from these nerves. And the term trigeminal cardiac reflex was coined by the two anesthetists actually from Southampton General Hospital, Shelley and Church, and I had the honor to work in that hospital. And the trigeminal cardiac reflex is considered as a brainstem reflex and is manifested classically. It's been described as a decrease in heart rate and arterial blood pressure of more than 20% from the baseline. But this is a very narrow definition, so it's more wise to define it as any cardiac reflex triggered upon stimulation of the trigeminal nerve anywhere along throughout its course. Now, recently, a criteria has been proposed for diagnosis of the trigeminal cardiac reflex, which has two major criteria: plausibility and reversibility. These are the two main major criteria. And then it has two minor criteria, which is repetition and prevention. Just briefly about the etiology and the pathophysiology, just to stress exactly the importance of knowing the anatomy of the trigeminal nerve. So basically, all the sensory information comes from any of the three branches along the pathway of the trigeminal nerve and the gastric ganglion alongside the trigeminal nerve, and then it goes, all the sensory information comes to the sensory nucleus in the pons and the brainstem. And then as a reflex, the efferent of these sensory information goes into the heart through the vagus and causes severe bradycardia and decrease in the heart rate and the mean arterial blood pressure. Now, it has many subtypes of this trigeminal cardiac reflex. The oculocardiac reflex, most of anesthetists actually are used to this, especially when patients are undergoing ophthalmology surgery, especially in pediatric patients who go strabismus surgery. The maxillomandibular cardiac reflex, which is extremely important when you go dental extractions. So it's extremely important to actually anesthetize these patients, especially pediatric patients, when they undergo teeth extraction. And this is one of the most important points that I always warn the anesthesia residents when they actually deal with dental surgeries, especially the wisdom teeth extraction, because it might cause severe bradycardia and patients may go even into cardiac arrest. And in our daily life, we always face it as a diving reflex, especially when people who swim and suddenly they go, actually it's summertime and it's too hot and suddenly they go into cold water. So our nasal mucosa gets wet and extremely cold and it causes a severe reflex bradycardia. So if you have loved ones, always warn them before going into severely cold water to actually expose themselves to very small amounts of water, especially in the nasal mucosa before going deeply into the water. And it has been actually divided into central versus peripheral actually reflex. And as we said, this classically, it's been actually the oculocardiac reflex and the maxillomandibular. Okay. And then the gastric ganglion and centrally through the brainstem. But more recently, it's been actually extended to include the skin, the nasal mucosa, and as we said, the diving reflex. And then centrally, as we said, as well as the brainstem, and this goes to our case where we work actually with trigeminal schwannoma. And in the diving reflex, it might cause especially irritations such as gaseous irritants and the forehead and especially cooling. And then the maxillomandibular, especially with surgeries on the mandible, especially with fractures of the mandible. Again, actually, we face it very often in neurosurgery when we work actually in tumors such as the cerebellopontine angle tumors, and more often with the skull-based tumors and transsphenoidal approach to the skull tumors. What are the risk factors and predisposition? mainly the type of surgery, ophthalmic, craniofacial, skull-based surgery, and again, I stress dental, and any procedure on the head, even if it's a minor procedure, could cause this reflex. And aggravating factors such as acidosis, hypercapnia, hypoxemia, and especially in young age patients, transient ischemic attacks, especially 6 weeks before the procedure. And I would stress on the drugs. So pre-operative assessment of your patients is extremely important. So to know that patients who are on beta blockers, calcium channel blockers, and patients who are on chronic use of opioids are much more prone to the trigeminal cardiac reflex. So just quickly to sum up this, an algorithm for treatment of the trigeminal cardiac reflex in case you face it, whether in daily life or in the OR, but we're talking here about the intraoperatively, so surgery in the territory of the trigeminal nerve. So we check some risk factors, as we said, acidosis, correct hypercapnia, correct hypoxemia, and continuous monitoring of mean arterial pressure and ECG is mandatory. So if we have a trigeminal cardiac reflex, we immediately inform the surgeon. So this is where communication between the surgeon and the anesthetist is of utmost important. And if there is no trigeminal cardiac reflex, we continue with the procedure. And then if needed, we use sometimes atropine, 0.6 milligram IV, and then if the patient is not responding, we use epinephrine of 6 microgram intravenously. And thank you very much.
Thank you. So trigeminal cardiac reflex. Remember that very carefully. You may be doing a sebaceous cyst in the outpatient clinic. A dental surgeon is doing wisdom tooth in his clinic. A few years back, one of our colleagues, a patient auxiliary surgeon, he lost a patient in the clinic because of this. And I think in the newspapers there has been a death of one young patient doing his dental work in Amman. My first encounter with this trigeminal cardiac when I was in training in London, we were doing a case, and as my boss was opening the dura, we had a cardiac arrest. So I was really worried, and he was laughing. And he told me about this, so I knew about it. And I always laugh at my residents when they just got screaming because of the cardiac arrest and opening the dura. We in the surgery use the navigation, and in this case it's very important. Any of the navigation people here? Nasib, and who is? And Salah. So what approach I'm going to use? I'm going to use the petrosal approach, anterior petrosal approach. So I will turn the head, so I would come this way. So when I retract the dura extradurally, I would see the carotid. This is petrous apex. This is the external ear, middle ear, the facial, the semicircular canals. I'm working here. Again, remembering the anatomy very well. So this is the patient. This is frontal, this is temporal, you go both. So you come across this, which is the meningio-orbital band, which is very important. You cannot open the severe orbital fissure unless you open the meningio-orbital band. And this way you go and open the dural leaves of the severe orbital fissure. But you have to know how to cut it, otherwise you'll cut the oculomotor nerve. So this is how to cut it. Once that is done, the severe orbital fissure is opened. You identify the middle meningeal artery. The foramen ovale is the trigeminal V2. And you identify the greater superficial petrosal nerve. This is the eustachian tube. This is the Kawasi triangle. And here is first ridge and second ridge of the temporal bone to recognize. So this is the Kawasi rhomboid, limited by the edge of the gazillion ganglion, limited by the greater superficial petrosal, by the internal tissue meatus, and by the petrous bone. Again, to show you V3 and V2. So this is what you are going to see during surgery in 3D. So this is the picture. V3, V2, V1. You will see all of them, the ganglion, the rhomboid area, and so on. Again, knowledge of the cavernous sinus anatomy. This is actual still pictures from my surgery. Or on the left side, we are taking the dura away from the bone, extradural approach. I'm drilling the sphenoid ridge, frontal temporal. I'm opening the meningio-orbital band to open the severe orbital fissure. I am cutting the middle meningeal artery here. I'm drilling the foramen ovale, and then I'm going to the foramen rotundum. Here, I'm doing that. And then continue the dissection. So when I dissect the dura now, I can come across the inner layer of the cavernous sinus, and I come across the tumor. So the dura has been retracted. This is the inner part of the cavernous sinus. You open it, the tumor would come into view. This is the tumor, you start debulking it. And these are the interdural approach. And this is posterior fossa dura, because this bone has been destroyed completely, as you have seen in the pictures. The petrous apex has been totally destroyed. So these are some of the branches of the trigeminal nerve going into the Caserian ganglion. This is V3. So again, this is the cavity that was occupied by the tumor. And this is the greater superficial petrosal nerve. Here I'm checking with the Doppler that the carotid is okay. And then I would fill the cavity with fat, put some fascia, put some glue. Let's see surgery in 3D and in 2D. If you don't see it in 3D, it means that your goggle is not working right. So on the screen here is the 2D and here is the 3D. You can compare the pictures. And you can see the difference. And you can see the teaching value of this 3D to understand the anatomy and the surgery. No books reading, no lectures can give you the feeling of the 3D to understand neurosurgery. And nowadays, when we go to conferences, we are not even allowed to present our work in 2D. It's always in 3D. So check that your goggle is working. Make sure that your goggles are working before we look at the 3D. First of all, compare the color and the light. It's totally different. So now it is 3D. Can you realize the 3D? You can see the depth. So if you see the depth, your goggles are working. So we're on the left side. We are going extradurally, meaning that we dissect the dura of the skull base. كله شايف 3D قبل ما نبدأ؟ If you don't, please tell us عشان نساعدك. Anybody who cannot see 3D, please tell us.
لازم يكون طالع برتقالي ولا احمر ولا احمر ولا بنفس الشو.
مش مهم اللون محمود، المهم انك تشوف الصورة.
انا شايف بس مش راضي تظبط ولا باي شكل.
معناها هنا خربانين.
عيوني مش النظام.
Dr. Ibrahim Sadat is happy to treat you. And Dr. Mahmoud is happy to treat anybody with hearing deficit. So, are we ready? Okay. So, 2D inshallah, yes, that's it. Compare the two pictures. In 2D, you don't see the depth. Here, you see the depth. Here, I'm using the drill. This is one of the venous connections. It is not the meningeal band. Still, it is far away. So I'm taking the dura off the skull base. And this is the skull base surgery. You drill the skull base so that you don't do much retraction. As you do that, this is the sphenoid wing. And you can see that here we are at the sphenoid wing. We drill it so that we can gain access to the superior orbital fissure. You cannot retract the dura unless you open the meningeal orbital band. So it is a must step. You must know how to open it. I'm opening it in a tangential way so that I will open interdural axis. I would not damage the structures within the superior orbital fissure. And here the closest is the oculomotor nerve. So once that is done, you can retract the dura, then you can find V1 and V2. So here I'm opening the meningeal orbital band. You don't learn this on patients, you will learn it in the cadaveric lab, and then you do it during surgery. Here, I'm opening the foramen ovale, I'm widening it so that I can do retraction. You can see that there's a tumor inside. Again, look at the difference between the 2D and 3D. Here I'm cutting the meningeal artery, and I always cut it above the foramen, otherwise it may slip and go into the canal and you cannot find it. It will bleed inside the foramen spinosa and it may kill the patient. Here I'm putting this introducer into the foramen ovale, which is harboring the mandibular nerve. And this mirror is to dissect it. This is called the rotor mirror or rotor dissector. This is all to gain access so that your vision is not obstructed by anything. Now, as I have opened V3, I'm moving to V2, which is the maxillary. And this is the space between V3 and V2. So superior orbital fissure has been opened here, V2 has been opened here, and V3 has been opened here. Here I'm putting the, we'll put the Doppler to make sure that this is here the ureter superficial arthrosis. If you damage it, you may get facial paralysis. Would you dissect it from back to front or front to back, whatever any technique you master, I'd like to dissect it from back to front. So you can see the difference between this dura and this layer, which is the inner layer. I'm trying now to dissect. See how I'm doing it? Trying to go in between the two dural layers, interdural dissection between the dura proper and the inner layer of the cavernous sinus. Again, using the Doppler to make sure that I'm not injuring the carotid, though I know from the images that the carotid is deeper than the tumor. but this is a necessary step. And also to teach the residents. You see my resident, I'm putting the Doppler here, there's no pulsations. But once we reach the carotid, I will make you hear the carotid pulsations. So here I have interdural, and the whitish stuff is the inner dura covering the tumor. So basically you are in the cavernous sinus. Cavernous sinus is here. So you have to know the anatomy. Don't say, I don't want to do, because everybody does not work in the cavernous sinus. You know the anatomy so that you would follow the tumor. Here is the opening, the capsule of the tumor. If you don't know your anatomy, you will not dare to do this step. You will not carry a knife and open the tumor. So this is the tumor. It is soft. Again, compare the 2D and the 3D. You can appreciate the depth of the surgery. I don't need to do drilling of the Kawasi triangle because the tumor has done the drilling for me. You have seen the CT scan. There's no petrous apex. But if the petrous apex is there, this is the petrous apex, and this is where you drill so that you will gain access to the dura of the posterior fossa. Again, you can never learn this unless you see it in 3D. So there in the depth, the white stuff is the Gazerian ganglion. And the tumor is arising from there. But it does not involve all the ganglion, it does not involve all the nerves. So it will involve some of the fibers. So if you do the surgery right, patient will not have trigeminal deficit. Easily here, as you are doing this, you may get cardiac arrest due to the trigeminal cardiac reflex. But again, if you are aware that this is the case, the anesthetic will tell you, cardiac arrest, you stop. So you wait a minute and then continue the job, and nothing will happen. Usually it's the first time. My experience that cardiac arrest or cardiac bradycardia will occur just once, but then if you wait, it will not happen again. But if you and your anesthetist are in line, and you know exactly what you are doing, there's no problem with that. So this is tumor being removed piece by piece. Or you may say here, I have done decompression. Decompression is another word, misleading word that the surgeons use to mislead their residents. They would say, we have done decompression, enough. Let's send them for radiotherapy. Again, misleading word like stable vital signs. Like the Glasgow Coma scale is good, so what? So basically, anatomy knowledge, and anatomy knowledge is in your brain. It is a 3D anatomy in your brain, and this helps you to master it. But if you don't have the image, don't have the knowledge, nothing will teach you. So this is the cavity where the tumor was. Now removing it. My aim is radical total resection of the tumor. If this is my wife or my daughter, I would like the surgeon to do his job properly, no matter how it takes. Again, neurosurgery is not a place for speeding desires. It is not a place for the novices. It is a place for experienced people who would commit their life and time and effort to save patients' lives. It is not to put screws in the neck of patients. It is not to put a shunt in the brains of kids. I have to come across and see the dura. You can see CSF is coming out. That means we are reaching to the posterior fossa dura. Again, this is the cavity where the tumor was. This is where the petrous apex was, and it is gone because now it is occupied by the tumor. Here I'm opening the interdural space more so that I can see better. can see the temporal lobe here. You can see it. So now, last bits of the tumor of the Gazanian ganglion and the branches. Total radical excision, not an ion of the tumor should be left. Whatever time it takes, time has no meaning here. This is a job that needs to be done. Being healthy, unhealthy, having troubles with your wife at home, it doesn't concern this patient. You need to do your job properly. Even if you have a personal problem, you leave them outside. This is called dedication. Again, here I'm showing you the V1, V2 cases. Look at the extradural space that we've created. And now we have to test for the carotid. What is the carotid? Are we okay? Did we damage the carotid? So because I've shown the residents the Doppler away from the carotid, they could not hear the carotid. But now we will put it in where we think the Doppler is. Here I'm making sure that the foramina are open. This is V2, and this is V3, and this is the foramen spinosum. This is the greater supraphyseal nerve there. Here's a teaching session for the residents. This is what, so they would understand. Now I know what is the carotid because I've seen the pictures and I know the anatomy. But I want to confirm it to my unbelieving residents. Maybe I am lying to them. Look at the cavity. This is Doppler. Voice, please. Can you put it back? Sorry. Then the cavity is filled with fat that you have taken from the thigh or the abdomen of the patient beforehand. And you put fascia lata that you have taken from the fascia lata from the thigh or from the temporalis muscle, or the fascial dura for that matter. Put another layer of fat. Fill the space. You don't want any dead space at all. Again, the presence of radiologist in this session, when he reads this is the geliform, and this is the duragel or the duracil to prevent CSF leak. The presence of a radiologist in this session would make him better positioned to report on the post-operative changes. And don't call them post-operative extradural hematoma, because he did not know that we use this technique. Sorry?
لا تخيط مطلقا لا تخيط
No.
لا تخيط
تخيط بس السكن والسبكتابس تشوز جوا.
طبعا انت حكيت انه الولد ممكن بس لما فات كان
I know, but a lot of people, I have seen it happening because they don't know the technique. Sometimes when you drill, you touch the sucker and some of the metals would go out and they would say there is a foreign body. So that's the value of these meetings, that we tell each other about these findings. Is to gain access, because you want to get access, because this bone in front of you, when you open it, you see more. So it is to open the space.
أخرنا إحنا كثير. You can see this mostly spindle cell tumor, myxoid stroma. The cells are usually bland, not hyperchromatic, and you can see most of the cells are really spindle cells. There are hyalinization around the blood vessels, as you can see here. It's indicating neurogenic tumor, and you can see some vascular spaces, and here you would some entrapped ganglions, and this is usually occurs more in neurofibroma than in schwannoma in these cases. And I did this 100, it's positive, nuclear and cytoplasmic. AMA, we do it to exclude meningioma, and it's negative. And progesterone is negative to exclude also meningioma. Factor 13 is usually negative in neurofibroma and positive in schwannoma, and this was negative. So with the absence of B53 was negative. So I call this neurofibroma actually because of the entrapped ganglions and because no typical Antony A, Antony B, and because of the factor 13 negativity. Case 7 was less than 1%. So I call this schwannoma or neurofibroma.
Again, schwannoma, it is schwannoma by histology. We call it trigeminal schwannoma because we know that it is arising from the trigeminal. So this is the post-operative course. She woke up on table, 15/15. On table, she must be awake. And we do immediate post-operative the following day, few hours after surgery. And you can see the fat that we have put. There is the fat. Layers and layers to prevent CSF leak because we have opened into the CSF area. Again, here you can see the cavernous sinus being freed. So this is immediate post-op. And again, here you can see the space and the fat. This is CT post-op. So she did well. She had some numbness in her face due to manipulation of the trigeminal, but then she improved dramatically, no pain, no numbness, and nothing. She was discharged. This is the patient doing well. This is still in hospital. This is her discharge summary, detailed, because she's going to travel to another country, so people there would need to know what exactly we have done, what investigations, etc. We followed her after 3 months. There's no tumor whatsoever. Again, you can see the fat that we have put in the space. You can see the free microscope. And this is follow-up of 1 year. And this is follow-up 2 years. And this is the patient. And again, thank you for everybody, all the teams, all the assistants, the nurses, the anesthesia department, the radiology department, everybody concerned. And on top of this is the administration provided us with everything we need in this hospital. Any questions, please, or comments? Any questions, any comments? Excuse me, any questions or comments?
No, one question, please. What about the use of Avastin, antivascular endothelial growth factor 1 in case of neurofibroma or schwannoma in neurofibromatosis? As I read that in neurofibromatosis,
it has no value.
Push the nerve, it's engulf the nerve.
It has no value, basically. In a nutshell, it has no value. Dr. Azam. Yes. Recurrence? Yeah, recurrence. I had two recurrences. If you do a total, you will not have recurrence. But if you had to leave it because it is stuck to the carotid or stuck to important structure, then there will be a recurrence, but usually after 3 years. I had 2 recurrences in my series. If no questions, we'll meet next week and I will present facial nerve schwannoma. Thank you very much.
Yeah, great. Hello.
Enjoyed it?
Can you hear me, Dr. Sbeih?
Yes, Jonathan. Yes.
Hey, how are you doing today? Very good. Thank you very much. The 27th year of giving this presentation is a multidisciplinary. There's one panelist especially that wants to ask you a couple of questions. Wasif, can you ask Dr. Sbeih the questions that you asked me? Can you unmute yourself, Wasif? Are you there? Go ahead. Introduce yourself, please.
Yes, I'm Dr. Wasif from Pakistan. I'm a resident neurosurgeon here. I wanted to ask you a few questions regarding your presentation. Initially, can you tell me what is the incidence of the neuro conversion of the
Yes.
And secondly, have you seen? And the second one was that you showed flashes representing fat saturation of MRI. So what was the benefit of that? Because normally we don't do here. So fat saturation MRI sequences, what are they purpose for?
Yeah, thank you. A question regarding the fat. We do fat suppression and fat augmentation so that we would show that the structure that you see in MRI is fat and not a tumor recurrence. And this is very important for the patient. And the second point that you mentioned is, what was it about the
de novo conversion of
yes, about the conversion of the de novo schwannoma into malignancy. This is reported that you may have initially schwannoma, and then if you follow it up even after surgery or recurrence, then you send it for histopathology, you excise it, and then you find that it has turned to be malignant. This is not very common. This is uncommon, but the common is in the neurofibromatosis. And maybe in the next session or the session afterwards, I'll present my series of neurofibromatosis. I have a very good series, and how dangerous it is to give them even radiation, because they would go really malignant. I had 2 cases of a neurofibromatosis, type 2, that needed or was treated by gamma knife, and then they did not respond, which is expected because the teaching is don't give radiation to neurofibromatosis. But still people, because they are not good in surgery, they do radiation, and these 2 cases tend to be malignant. So I had malignant tumors developing in the area of the radiation. Because to diagnose that, you have the CAN criteria. CAN criteria is to define when is this case is due to the radiation. So it has to be within 5 years, it has to be in the same area of radiation, and you have to have a histological diagnosis. And I have this in my 2 cases, which we are going to present in the coming sessions.
Thank you very much.
Okay, well, any more questions, Wasif, or that's it?
Thank you, sir. It was a very nice presentation. Learned a lot, especially regarding the cavernous sinus surgery. We never do it here, but it was a pleasure, definitely.
Thank you.
Okay, very good. Any more questions for the panelists for Dr. Sbeih? Badr, any questions? Nadia, Dr. Weil? Do you want to say hi to Dr. Sbeih? Well, I guess the panel's quiet. Oh, go ahead. Go ahead.
Good evening.
Good evening.
I'm Dr. Badr from Iraq.
Yes.
I'm 6th year Arab board student. Thank you very much for this rich presentation, sir.
Thank you.
I want to ask you about how you deal with the recurrent cases or subtotally excised cases.
You have the 2 options, either to go for excision and try to remove as much as you can, because if you know that you have removed the tumor subtotally, then you don't go for radiation as upfront. So meaning that if I have a tumor and I could not remove it completely, and there is a remnant which I had to leave on the basilar or the carotid or the abducent or the oculomotor, I don't go and give radiation straight away. I wait. Most of the time that residual will not grow further. But if it does, then you have to think either of 2 ways. If the tumor is large, then you go for another debulking and then send the patient for radiosurgery.
Okay. Thank you, sir. Thank you very much.
Very good, Dr. Sbeih. I'd like to thank you very much, and we'll see you next week.
Next week with the facial schwannoma.
Okay, very good. We'll announce it. Okay. Thank you.
Hello, Dr. Weil. I have Dr. Weil from Sudan.
You remember Dr. Weil? There you go. You're getting to have regular visitors.
He joined us in Jordan. He's a very loved person here in Amman.
Very good. This is a great way to network, Dr. Sbeih. Great to meet other neurosurgeons.
We have opened the training for many residents. We have residents coming from Sudan, Libya, Qatar, Iraq, everywhere for training in skull-based surgery for 6 months. This is supervised by the World Federation of Neurosurgery. And Dr. Weil was one of them. He spent 6 months with us as a skull-based fellowship.
Oh, excellent. We could announce that on your presentations that you do accept fellowship, 6-month fellowships. That's
6 months fellowship, yes.
Okay, we can put that on the announcement for this on this video that you're accepting application for 6-month fellowships.
True.
Very good. Okay, we'll see you next week, Doc.
Thank you. See you all. Bye-bye.
Thank you. Bye-bye.
Bye-bye.